Imagine beating a deadly, aggressive cancer, right? You go through the brutal treatments, you finally get to ring that bell in the oncology ward, only to discover that, well, the very treatment that just saved your life has caused your body to age a decade overnight.
Yeah, it is the harsh reality for millions of survivors. The medical focus is just so intensely locked on eradicating the tumor.
Right.
So the aftermath, that profound biological collateral damage, it rarely gets discussed until the patient is already suffering from it.
Which is just heartbreaking. You survive the disease, but your overall quality of life is completely shattered. So today we are taking a deep dive to answer a highly specific and frankly deeply sensitive question.
Yeah, it's right at that very tricky intersection of oncology and regenerative medicine.
Exactly. And the question is, are intimate polynucleotides actually safe for cancer survivors?
Yeah, and answering that requires navigating a lot of heavy science, because for these patients, the standard treatments, they're often completely off the table.
Yeah, and the heavily marketed alternatives out there can be incredibly dangerous.
They really can.
So if you are navigating survivorship right now, or maybe you're supporting a partner through recovery, you know that finding relief from post-treatment complications is just an absolute minefield.
It's overwhelming.
To really get to the bottom of whether polynucleotides are the answer, we have to first look closely at the biological landscape that's left behind by cancer therapies. Basically, we're talking about dealing with iatrogenic menopause.
Right, and the clinical distinction there is really severe, because natural menopause, it's a gradual decline in ovarian function over a period of years. The body actually has time to adjust to those lower estrogen levels.
It eases into it.
Exactly.
Yeah.
But iatrogenic, or medically induced menopause, is an abrupt systemic crash. It happens overnight.
Just a total shock to the system.
Yeah. Chemotherapy agents, they target rapidly dividing cells to kill the cancer, but that inadvertently damages healthy ovarian follicles. And then you have pelvic radiation, which permanently alters the vascular structure of the reproductive organs.
And for breast cancer survivors, the deprivation is even more intentional, isn't it? I mean, drugs like aromatase inhibitors are literally designed to starve the body of estrogen.
They are. They block the enzyme aromatase, which is responsible for converting androgens into estrogen. So the resulting estrogen deprivation forces the localized tissues into severe atrophy.
Right.
Clinically, we call this Genitourinary Syndrome of Menopause, or GSM.
And the symptoms for GSM, they are brutal.
Oh, absolutely. The vaginal wall thins out dramatically, it loses its elasticity, and the natural microbiome just collapses.
Wow.
Yeah, so this leads to intense dryness, recurrent urinary tract infections, and just debilitating dyspareunia, which is painful intercourse.
And we really need to emphasize that the scale of this issue is massive. This is not some niche, rare problem.
Not at all. I mean, if we just look at the clinical trial data on HPV-associated cancers.
Like cervical and anal cancers?
Yeah, cervical, anal, and vulvar cancers. There are over 600,000 new cases diagnosed globally every single year.
God, 600,000.
And thanks to aggressive chemoradiotherapy, the survival rates are actually improving. But a systematic review of survivors of anal squamous cell carcinoma, or ASCC, it showed that up to 85% suffer from severe post-treatment sexual dysfunction.
Wait, 85%.
85%.
So you have these women who had perfectly healthy, active, intimate lives, and suddenly, because of the exact treatment that saved them, physical intimacy is excruciating.
Exactly. And naturally, these patients go looking for standard care. They want relief.
Right. So they start with simple, over-the-counter moisturizers,
which are, frankly, functionally inadequate for severe tissue atrophy. I mean, they provide some temporary friction relief, but they do absolutely nothing to reverse the underlying cellular degradation.
So what's the next step?
The standard medical escalation from there is usually local vaginal estrogen.
Okay, but introducing estrogen to a woman who just survived, say, an estrogen receptor-positive breast cancer, that seems like a massive contradiction to me.
It is a terrifying prospect for a lot of people.
It's like surviving a devastating house fire because the firefighters soaked the entire building, right? But now you have to live with the severe water damage.
Because it's a great analogy.
You're freezing cold, but you're told you can't use a space heater to dry the place out because, it might spark another fire.
Yeah, and the fear of recurrence is a paralyzing factor for both the patient and the oncologist. Because, well, estrogen was literally the fuel for their tumor.
But wait, looking at the NICE guidelines from the UK and the North American Menopause Society recommendations, they actually state that local estrogen can be considered for these patients if the non-hormonal options fail.
They do say that, yes.
If estrogen is so risky, if it's known tumor fuel, Why is it even listed as an option in the medical guidelines?
Well, it really comes down to the mechanics of systemic absorption versus localized application. The guidelines acknowledge that when you apply a vaginal estrogen cream, the amount that actually permeates the mucosal barrier and enters the bloodstream is exceptionally small.
Okay, so it's not like taking an oral hormone replacement pill.
Exactly. It's much, much lower. So for a patient with a relatively low risk of recurrence, whose life is just being entirely derailed by GSM, an oncologist might determine that the quality of life benefit outweighs that localized theoretical risk.
Oh, I see.
It's a highly individualized shared decision.
It's still asking a survivor to roll the dice, though. I mean, they are desperately looking for a way out of that trap, and that desperation has really fueled this booming market of aesthetic, non-hormonal regenerative therapies.
Well, yes, it's become a regenerative Wild West out there. Because hormones carry that heavy psychological and physiological risk, aesthetic clinics have just swooped in.
Right.
But we have to be clear, just because something is marketed as natural or regenerative does not mean it's safe in an oncological context.
Let's run through these alternatives because listeners have probably seen ads for them. First up, transvaginal lasers. They're heavily marketed as a way to, resurface the tissue.
Right, so the mechanism of a laser is controlled thermal injury. It essentially creates microscopic tears in the tissue, which prompts the body's natural healing cascade to rush in and build new collagen.
That sounds somewhat logical, right?
In theory, yes. However, the UK's NICE guidelines explicitly state that transvaginal laser therapy should not be offered outside of randomized controlled trials.
Wait, really? Why?
Because we simply do not have the longitudinal safety data on how previously irradiated or chemotherapy-damaged tissue is going to respond to thermal injury over the span of 5 or 10 years. It's an unknown.
That makes sense. Okay, then there's PRP, platelet-rich plasma. That's where they draw your own blood, right? They spin it in a centrifuge to isolate the healing platelets and then inject it back in.
Yes, and actually the Mayo Clinic is currently running phase 2 trials investigating PRP specifically for breast cancer survivors with GSM.
So that's promising.
It is. The premise is very sound, using the patient's own autologous growth factors, but it is still experimental. We don't have the definitive peer-reviewed endpoints yet to say it's a standard of care.
Okay, but the most heavily marketed treatment right now, and the one raising the most alarming red flags in the medical alerts that we looked at, are exosomes. I mean, clinics are selling these intimate exosomes as the ultimate cutting-edge repair tool.
Yeah, and that is where we run into major issues. Both the FDA in the US and the MHRA in the UK classify injectable exosomes as unapproved medicinal products.
Unapproved.
Completely.
Hmm.
And to understand why they are so heavily scrutinized, you really have to look at how they function on a cellular level. Exosomes are nanoscale extracellular vesicles.
Meaning what, exactly?
There are tiny lipid bubbles, roughly 30 to 150 nanometers wide, that are naturally secreted by cells.
So they function kind of like a biological postal service.
That's a perfect way to frame it.
Yeah.
They carry payloads, proteins, lipids, and crucially genetic material like microRNAs from one cell to another.
Okay.
In regenerative medicine, they are isolated, usually from stem cells, and then injected into damaged tissue to deliver a very specific message: grow, repair, replicate.
But wait, if they are just messengers telling cells to heal, why is that an issue for someone who is in remission? Don't we want the tissue to heal?
We do, but you have to remember what cancer is. Fundamentally, cancer is an uncontrolled healing and growth process. It is cellular replication that has entirely lost its regulatory brakes.
Right.
And exosomes are blind messengers. They do not distinguish between a healthy, aging fibroblast that needs a boost and a dormant, disseminated tumor cell that might be hiding in the tissue.
Oh, wow. So they just broadcast that growth signal to whatever is in the neighborhood.
Exactly. Preclinical oncological data shows that the microRNAs inside these exosomes can radically alter the tumor microenvironment.
Even if the exosomes come from healthy cells?
Yes. Even when exosomes are derived from perfectly healthy non-cancer stem cells, studies have shown they can stimulate the growth, migration, and oncogene expression of triple-negative breast cancer cells.
That is terrifying.
They can downregulate tumor suppressors, or they can even upregulate angiogenesis, which is the formation of new blood vessels that literally feed a tumor.
You are basically fertilizing the soil in an area where a malignant seed might still be hiding.
Exactly. Injecting an unapproved biological messenger that indiscriminately promotes cellular proliferation into a cancer survivor, it's just an unacceptable clinical risk right now.
So to recap where we are, Hormones are a terrifying gamble for many. Lasers lack long-term data on damaged tissue. Exosomes are a biological megaphone that could wake up a dormant cancer cell. The failure of those treatments is what really pushes us to find something that provides the building materials for repair, but without shouting at the cells to multiply.
Precisely. And this is where polynucleotides enter the picture.
The clinical shift toward polynucleotides, specifically highly purified formulations like Nugen, it offers a completely different biological pathway, doesn't it?
It does. It fundamentally changes the approach.
Now, the source of these polynucleotides usually catches people off guard. I know it surprised me. They are highly purified DNA fragments extracted from the sperm cells of salmon or trout.
I know, using trout DNA sounds completely bizarre at first, but when you look at the genomic architecture, it makes perfect sense. Trout DNA shares an incredibly high degree of spectral compatibility with human DNA.
Okay, let's break that down. What does spectral compatibility actually mean in this context?
It refers to the physical and chemical properties of the DNA molecules. The ratio of purines and pyrimidines.
The structural rungs of the DNA ladder.
Exactly.
All right.
The ratio of those rungs is remarkably similar to human nucleic acids. And because the structural mimicry is so close, human cells can seamlessly integrate and utilize these fragments as raw material.
Okay, but the immediate red flag for me, and probably for anyone listening, is allergies. Like, fish allergies are severe. If you're injecting fish DNA into someone, isn't that incredibly risky?
It's a very common question. But we have to understand how food allergies work. They are immune responses triggered by specific folded protein structures. Your immune system recognizes the shape of that protein and attacks it. This is where the manufacturing process of these injectables, known as high purification technology or HPT, is so critical.
It's a multi-step thermal and chemical extraction process,
Yeah.
right?
And it completely degrades and strips away 100% of the proteins, the lipids, and the carbohydrates. What remains is purely the naked nucleic acid chain.
Oh, I get it.
Yeah, because there are absolutely no protein structures left for the immune system to recognize, the risk of an immunogenic or allergic response is virtually eliminated.
So if exosomes are a boss shouting, "Work harder," over a megaphone, which risks waking up a dormant cancer cell, polynucleotides are more like they're just quietly dropping off a pile of bricks and mortar so a healthy tissue can rebuild itself at its own pace.
That is a perfect analogy, and that distinction is the core reason they are viable for oncology patients. They are entirely non-hormonal, so they don't bind to estrogen receptors at all. And they don't act as active signaling molecules forcing cell division like exosomes do. They act passively. When they're injected, they just restore the localized pools of nitrogen bases in the dermis and the submucosa.
They give the fibroblasts the raw materials they desperately need.
Exactly. And fibroblasts are the cellular engines responsible for synthesizing your collagen, your elastin, and all the structural framework of your tissue. In iatrogenic menopause, those fibroblasts are starved and sluggish.
So by bathing them in these purified DNA fragments, you increase their metabolic activity, but organically.
Precisely. And it's not just the DNA fragments doing the work alone. Advanced formulations like Nugen, they actually combine the polynucleotides with hyaluronic acid and mannitol.
And why is that combination so important?
Because fibroblasts cannot function in a dehydrated environment. They require a deeply hydrated extracellular matrix to synthesize collagen effectively. The non-cross-linked hyaluronic acid in the formula provides immediate, profound water retention right there in the tissue.
But the body naturally breaks down injected hyaluronic acid pretty quickly, doesn't it? It uses an enzyme called hyaluronidase.
It does, which is exactly why the addition of mannitol is so vital to this process. Mannitol is a sugar alcohol that acts as a potent antioxidant.
So it protects it.
Yes, it scavenges the free radicals that typically accelerate the degradation of the hyaluronic acid. So by shielding it, the mannitol significantly extends the lifespan of that hydration.
Giving the polynucleotides the time they actually need to facilitate that architectural repair.
Exactly.
Okay, so the biological mechanism makes total sense. You hydrate the environment, you protect the hydration, and you supply the raw DNA building blocks. But how does this actually translate to the clinic? What happens when a survivor goes through this specific protocol?
Well, the clinical outcomes, which were published in the European Journal of Obstetrics and Gynecology, they specifically address this vulnerable cohort. The researchers followed 60 women with breast cancer who were actively on adjuvant therapy.
Meaning their bodies were being intentionally starved of estrogen to prevent cancer recurrence.
Right. That is arguably the most difficult demographic to treat for GSM.
So what did they find?
They utilized a topical polynucleotide-based formulation over a 6-month period. The clinical investigators tracked vaginal pH, tissue elasticity, vaginal health index scores, and overall patient satisfaction.
Ah,
The data showed highly significant improvements in reversing atrophy and managing symptoms, with zero adverse oncological events. It was exceptionally well tolerated across the board.
that's amazing. But the topical application is mostly for maintenance, right? The injectable protocols seem to offer a much more aggressive reversal of the damage. For instance, there is a detailed case report in the sources documenting a 42-year-old woman treated for HPV-positive anal squamous cell carcinoma.
Yes, that case study is really illuminating. She had undergone very intensive chemoradiotherapy, and while it successfully eradicated her malignancy, the localized radiation caused severe structural damage.
Right, her vaginal canal had narrowed, the mucosal tissue completely atrophied, and she suffered from severe dyspareunia, which entirely disrupted her intimate life.
So her clinical team administered the Nugan protocol. And this wasn't just a topical cream. It involves 6 actual clinical sessions over 4 months, injecting the polynucleotide and hyaluronic acid matrix intradermally and submucosally.
Injecting at those specific depths is critical, isn't it? Because it bypasses the dead surface layers.
Exactly. It deposits the matrix directly into the dermis, which is exactly where those dormant fibroblasts are located.
The functional recovery in that report was staggering. I mean, within the first 2 sessions, her symptoms of burning and itching dropped by over 50%.
It's a very rapid initial response.
Yeah, and by the end of the follow-up, her dyspareunia scores fell by almost 60%. The tissue visually reversed its atrophic signs, and within just 3 months, she was able to return to a normal, satisfying sexual life.
You really see the synergy of the formulation in that timeline. The hyaluronic acid provides the immediate mechanical cushioning and moisture, which offers rapid symptom relief and really helps the patient's psychological recovery.
Because they finally feel some relief.
Yes. And meanwhile, the polynucleotides are working over those several months to fundamentally rebuild the tissue architecture from the ground up.
Okay, so if the clinical data is this strong and it completely bypasses the risks associated with hormones and exosomes, why isn't this the immediate first-line treatment offered to every single cancer survivor the moment they complain of discomfort?
It comes down to 2 major factors: clinical governance and the physical demands of the procedure itself. Medical protocols universally dictate a stepped approach to care. You must exhaust the least invasive, most economically viable options first.
Even if the basic moisturizers rarely solve severe iatrogenic atrophy, you still have to tick that box on the chart.
You do. Furthermore, injectable polynucleotides are a highly specialized clinical intervention. They require a practitioner who is specifically trained in submucosal injection techniques. And more importantly, there are absolute contraindications.
Like what?
UK safety standards explicitly state that ongoing cancer therapy is a strict barrier to treatment.
But wait, if the substance itself doesn't cause cancer, why is active chemotherapy a deal breaker?
Because during active systemic treatment, the patient is severely immunocompromised. Their white blood cell count is decimated. You absolutely do not introduce elective procedures that involve breaking the skin or mucosal barrier, even with a highly purified, sterile product.
Because the risk of secondary infection is just way too high.
Exactly. The oncological treatment takes absolute priority. These regenerative therapies are strictly for the survivorship phase, once the patient is in remission and their immune system has finally stabilized.
So they are an adjunct therapy. You get oncology clearance, you continue your foundational tissue care with moisturizers, and then you use this to rebuild.
Exactly. It requires an in-depth assessment by someone who understands not just aesthetic gynecology, but the actual oncological history of the patient.
Let's pull all of this together for the listener. The reality of surviving cancer is that the therapies that save your life often leave behind the severe biological devastation of genitourinary syndrome of menopause.
And the traditional medical response usually forces survivors into impossible choices. Localized estrogen carries complex risks for hormone receptor-positive patients.
Right, and experimental treatments like transvaginal lasers lack long-term safety profiles on irradiated tissue.
And then injectable exosomes present an unacceptable risk of altering the tumor microenvironment and stimulating rogue cellular growth.
So highly purified polynucleotides sort of navigate right through the middle of that minefield. By utilizing the spectral compatibility of fish-derived DNA, completely stripped of immunogenic proteins, they deliver the raw materials fibroblasts need to rebuild tissue.
Yeah, and when combined with hyaluronic acid and mannitol, they restore hydration and structural integrity without relying on hormones or aggressive biological signaling.
If you are listening to this deep dive right now and you are dealing with the aftermath of cancer treatments, the most critical takeaway is that you have options that do not compromise your oncological safety. You must advocate for yourself.
Absolutely. Seek out a medical specialist who operates at the intersection of regenerative medicine and oncology, someone who relies on clinical data, not just aesthetic marketing.
You do not have to accept chronic pain as the permanent price of survival, but you also have to be vigilant about the science you trust to heal you.
When you look at the broad arc of what we've discussed today, it highlights a profound paradox in modern medicine. To eradicate a malignancy, we use highly toxic radiation and harsh chemotherapy to literally break apart and destroy human DNA.
Yeah.
And then, when the disease is finally gone and the patient is left in the ruins of that cellular warfare, we extract the purified DNA of a fish, relying on a structural mimicry millions of years in the making to stitch the quality of that human life back together.
It's kind of beautiful when you think about it.
It really is. It forces you to wonder, as we continue to sequence and understand the genetic blueprints of the natural world, what other ancient cross-species building blocks are hiding in plain sight, just waiting to help us heal our most complex traumas.